Good morning. Thank you very much for joining, and we are about to start in another 1 minute. So please bear with us. Thank you. Thank you very much, and good morning, everyone. My name is Chandrakant Laharia, and today I'm going to moderate this conversation on a topic which sometimes may appear very intuitive. We often talk about that medical colleges have a role in delivery of entire healthcare services, and why somebody should be talking about that community medicine department, which are grounded in medical college. Why should we be talking about that, how they can deliver primary healthcare services? The fact is that the founding fathers of medical education in India, from the very beginning, had thought and reflected that medical education should not be restricted to the four walls of a hospital or a medical college building. The entire idea was that the medical doctors, and not only medical doctors, in fact, healthcare workers, be it doctors, nursing professionals, physiotherapists, any group of healthcare workers, when they are trained, they should be exposed to the community and settings. So their practice and their experience is grounded on what communities and people face, and not just focus upon sick people. So in Indian healthcare system, Indian medical education system, from the very beginning, the training of medical doctors is planned in a way that while they are trained on a sick patient in hospital setting, but they are exposed to the community setting. As part of this process, more specifically, and today our focus is on mainly medical doctors. As part of the curriculum and as part of the entire training program, a community medicine department in each of the medical college is attached with a few primary healthcare facilities. Usually it's a 2 primary healthcare facility, rural area, 1 urban primary health center. All of the medical colleges do have that, but the fact is that the functioning of those attached primary healthcare facility is variable across the country. While some medical colleges do it really well, others, the students rarely get the opportunity to be exposed to the community. And I think that's a big challenge. If you do not send the medical graduate and postgraduate to the community setting, they are bereft of the ground reality. They do not understand the pain and trials and tribulation of the common citizen. I think India's medical education system requires some rethinking. And what we are going to do today is start the dialogue. We are not going to get all the answers, but start the dialogue that how some of the medical colleges in India are delivering primary healthcare services through community medicine department. What are the challenges? What are the learnings? And this is a conversational format. So what I'll do, once the session chair will speak, then we have an expert speaker who would share the experience from the medical college. Then I'll have a few question and answer session, and then we will open for the audience or viewers. The viewers can type their question throughout the process through YouTube channel, and I'll ask those questions to my expert speaker. Once again, This webinar is being organized by Foundation for People-centric Health System. My name is Chandrakant Laharia. I'm going to moderate. For this, chairing this session, we have Dr. Subodh S. Gupta. He's a Director, Professor and Head, Department of Community Medicine at MGIMS Sevagram. He's the chair. Thank you very much, Dr. Gupta, for joining. Welcome. The expert speaker, we have Dr. Ramakrishna God. He's a professor at the St. John's Medical College, Department of Community Medicine there, and also affiliated with many other community outreach programs. So without further ado, I thank both of the experts, session chair, Dr. Gupta, speaker, Dr. God, and hand over to Dr. Subodh Gupta.
Thank you so much, Dr. Chandrakant, for inviting me for this dialogue, as you are saying. The topic you have chosen is very, very important. So medical education is going to play a very important role in the kind of health professionals that we create. And Department of Community Medicine will have to play an important role in it. Thinking about the topic, and before Dr. Ramakrishna God speaks, I would just like to put a few points. Each medical college or Department of Community Medicine must have a field practice area where not only the students, but also the faculty members and teachers learn. It provides a platform where they can learn about the community, things that we may not be exposed in a tertiary care setting. And this setting must be utilized for authentic learning situations where real life students are able to see people practice, their teachers and other professionals practice primary health care. So a role modeling is required. Somewhere, many medical colleges are doing this, but in a larger scenario, probably we are missing this role modeling. And one point which comes to my mind is it is not only for medical students, already you have emphasized, but it may be for in-service capacity building, other cadres, even health managers, them to see how this can be provided. So with an aim to produce a sensitive and responsive doctor, which is aware of community health needs and has requisite skills to address the current challenges and future challenges in healthcare, this is very, very important. When it comes to today's speaker, we already know St. John's Bangalore has a long history of providing primary health care and a very strong Department of Community Medicine. So it's a pleasure to invite Dr. Ramakrishna God for his talk. And we understand that it would be a great learning for all of us. Thank you. And I request Dr. Ramakrishna God to deliver his talk.
Dr. God, you are on mute.
Thank you, Subodhji, and thank you, Chandrakantji, for giving me this opportunity. And while we get invited to many forums, all of us, but nothing like when you get a call from your own tribe, the family. So it's a great pleasure, sir. It's an honor. And whatever I say today, I speak for all of my colleagues at the Department of Community Health. It's our collective experience, our collective efforts, and our collective wisdom. If at all something comes across positively, the credit is due to all of my colleagues at the Department of Community Health and our teachers and seniors who have laid the foundations for this department. While there are appreciations for us, but humility must prevail, and we have no hesitation in saying we do have limitations, but we have a will to take forward the spirit of our subject and of our specialty. Recognizing those challenges and overcoming them, God willing, and ultimately to serve the humanity with all the principles of community health in place, and ensuring people are empowered and are enabled to take their decisions to the best of their ability for their own good, because ultimately that's what is sustainable, sir. With that note, चंद्रकांत जी, आपने सजेस्ट किया था मुझे एक छोटा सा प्रेजेंटेशन के लिए. मैंने have put few slides there. Should I share the slides or shall we have this conversation? Because I want to go it the way you, Gupta sir, and you both have planned. So I'm okay by any way.
I think the idea of slides is to set the context. So I would request that if you can just outline that what all is being done, and then we will pick the conversation from there.
Okay, then I will do that.
The entire discussion, we want to focus upon that how difficult or easy it is, how to sustain, what are the challenges. So we want to go on more of an analytical part, but the context setting would be done by the slide. So
okay, so then you should help me share my slide.
I think my team will help from the backdrop. Yeah. You have a share screen.
Yeah. And Chandrakant ji, we also have our fellows on the other side. Namaste sab logon ko, hearty greetings from my institution, St. Joseph Medical College, to all of our fellow students there out there.
Yes. So people are watching this directly from the YouTube live. Okay. So they would write the question and other aspects. So do you have a right to share the screen? Can you share the screen?
Yeah.
Okay, you go ahead.
Is it visible?
Yes, we can see your slides.
Is it on a... Okay. It's fine now, Chandrakanji? Subhath sir, is it okay?
Yes, it's visible and you are audible. Go ahead.
You can make full screen on through the bottom corner, and then it will be like even better. Yeah, this one.
Okay, great. So thanks a lot. I think then we'll get on with it. So Chandrakanji, like you have said, and Subodh sir also has mentioned, there's a great need for the art and science of community medicine to be practiced out there. And the best way for that to happen is the teachers, the leaders doing it, and our teachers and our students, including both undergraduates and postgraduates and fellows who who choose our specialty for an experience in our specialty, to see we doing it. I think that sets the ball rolling. It's like surgery postgraduate, learning the art and skill of doing surgeries by seeing, his teacher, his assistant professor, their SRs, and their, senior faculty members doing it, and learning from them and improvising and innovating, etc. Likewise, it should be the case with community medicine also. Community medicine is a practical subject. It is a subject that needs to be practiced. And that, I think, will be one singular message to our colleagues who is watching this small interaction. Community medicine is a subject that needs to be practiced. And that's what the subject is all about. And only when we practice, we will be able to assimilate this subject better, and we will be able to be better ambassadors of this subject. When I say better ambassadors, I mean better teachers, better colleagues, and better professionals out there in this big wide world. So that is my first statement for the day. Now, where do our students learn community medicine? Obviously, we have a National Medical Commission. We have the medical colleges affiliated to the National Medical Commission, and we have a department that is recognized to be having the expertise in teaching the community medicine. That is Department of Community Medicine. Some departments out there call themselves preventive and social medicine. Some of them call social and preventive medicine. And yet some departments call community health and preventive medicine, community health and family medicine. It doesn't matter. It goes by various names, but the norm in our country at this point of time, as we speak, in most places, our specialty is known to be Department of Community Medicine, Preventive and Social Medicine, Department of Community Medicine and Family Health, Department of Community Health. So at St. John's, we call ourselves Department of Community Health. And the work that we do, I, in humility, state that like any other department, we do the stuff, but we also go a little bit more into primary care. like family medicine and what exposed in the family medicine. So we call ourselves also the primary care physicians, because we have a whole lot of clinics that we run at our rural health training center and at our urban health center. Probably that's what prompted Laharia ji to speak to our fellowship students. That is, how do we teach community medicine by practicing it? So the philosophy that we have at the Department of Community Health is this. Our institution, St. John's motto is to reach the unreached. So my department's philosophy goes with that line. So we are there, we are within reach for those who need us, and we reach out to those who have no access to health. So that's what we strive to do. And like any other departments of community medicine or preventive and social medicine departments, we also have a teaching mandate, service mandate, and a research mandate. While teaching is done in all the departments, we at the department are heavily service oriented, and whatever the research that we do at the Department of Community Health, that research comes out of the service we do. So we believe in service-driven research. And the other thing that we keep saying in the department is no survey without service. So everything that we do in the department is, especially the research, it comes out of the services that we do. So undergraduate teaching, allied health teaching, postgraduate teaching, and we also have a very good course. We call it Basic Community Health Workers course. We have had close to about 50 batches thus far. And that is a course meant for the lay people out there. And we have many NGOs who send their folks to get trained with us. It is a 6 to 9 weeks course. And off late, whole of our training program is booked off by our mission institution brothers and sisters. But we are open to any NGO or anybody who is wanting to train their staff in basic community health work. And we have laid the foundation for the NMC mandated foundation course in the institution. In fact, even before the NMC stated foundation course, we had a solid iron frame to do this course. And that was in the form of the Rural Orientation Program and the Community Health Action Programs, which are very, very unique to St. John's. And I do understand two other institutions, this CMC Vellore and Ramaya Medical College here in Bangalore also do this. And we also have an urban orientation program. Urban orientation program is again for our undergraduates and postgraduates. While we do clinical socials and family studies out there in the open, we also take the teaching opportunities, also give a gross orientation to our students, not only to look at sick people in the families and challenge families, but also understand, identify, and assimilate the utility of social determinants of health. So that's what we do. Then health services offered. I think this is where the pitch is in today's session, how the community health department or community medicine departments can actually deliver primary healthcare services to those who need through the departments. I think that is a pitch for today. So I will cut short many of the other things that I have lined up in the interest of the time. So I will heavily focus on our primary healthcare services through which we reach out to the people who need it and the people who have no access. So to begin with, we have, like any other medical college, we too have a rural health training center. We call it our rural health training center, St. John's Community Health Training Center, which was set up about 40 years ago, almost. And that serves as our headquarters for all of our outreach activities to the rural areas. Through our rural health training center, we reach out to close to 30 villages in a very, very concentrated way with dedicated, structured health services. But because of some unique services such as the IL services that we have, and the senior citizens health service and the mental health service, which I direct that program, many people have come to know of services, and we have people coming from up to 50 to 100 villages to seek services that we provide under these clinics. Excuse me. Excuse me. So, yeah. So at St. John's Community Health Training Center, we have it's a health center. We have a resident medical officer, full-time resident medical officer. Along with the resident medical officer, we have our postgraduates who are posted there in rotations for a period of 4 months. They stay there, they live there. In fact, I keep telling my postgraduates that when you are here, you are not the resident medical officers of the center. You are here, you will function as the resident medical officers of the community. So that's what they do. And we provide 24/7 services. Then we run a general OPD, obviously, in which all sorts of problems are taken care of. We also have dedicated maternal and child health clinics, including very recently, we also kind of used to conduct deliveries, but now because of the advent of the government of India and our state government schemes, many of our people prefer to go to a government health center and deliver so that they can get all the entitlements that are due to. But we are also geared up to do deliveries if required. We also have special clinics in the form of women's clinic, which is true to any community health department. Mother and child health services are, the foundations for our departments. So likewise, we also have here. But a couple of years back, we have begun to call our mother and child health services as women's health service. And we take care of women from age of 18 till whatever the age. So we have everything that is required for them in this Well Women's Clinic, and not just ANC and PNC or immunization. We do everything. And we also have ophthalmology services, thanks to CBM International, who have been with us for a long time, and our ophthalmology department. We also have a full-fledged ophthalmology unit at our Rural Health Training Center, wherein we conduct cataract surgeries. It was a pandemic which stalled all of our works, but otherwise, on an average, we used to do about close to about 20 to 25 cataract surgeries in our rural hospital, which had a complement of our staff and also the Department of Ophthalmology colleagues. Then we have ENT services, which we do in collaboration with our ENT department. And with a collaboration of the Department of Psychiatry, we have Manasi, the Rural Mental Health Program, wherein every Friday we run a clinic wherein we address the common mental disorders that our people face in the rural area. That we do in collaboration with our psychiatry department, and we have support from the Rotary clubs for almost 2 decades now. Then we have disability and rehab services, wherein we very focusedly take care of children with different abilities. And we also do some work to address the caregiver's burden, which is a reality in almost all the chronic diseases, and more so among the primary caregivers who take care of our children with different abilities. So we are little sensitive and oriented to that care as well. And we have senior citizen service, which we do. It takes a lot of our time nowadays, wherein we reach out to the people above the age of 60 through about 6 to 8 clinics that we conduct in various villages, including a urban health component. And we also have a dermatology clinic that happens on Thursday. We also have our surgeon colleagues coming in to take care of the people who have any surgery related issues. We call it the super specialty clinic, which happens every 3rd Thursday of the month. And why I'm saying all these things, Subodh and Laharia ji, is if an undergraduate and a postgraduate of a specialty see all these things happening in our workspace, then what happens? Community medicine just doesn't end up being a subject which is taught for the sake of teaching and for the sake of answering 2 question papers in the university exam. Students will realize that it is a subject which actually has a lot of practicality in it. It has got a practical orientation, and most importantly, from a utility point of view, it encompasses the spirit of primary healthcare, which back then Joseph Bore Sahab, and then later on the Alma Ata Declaration brought to the fore. That's what, if at all anybody, any specialty in our medical fraternity can do this, it's us, I think, the community medicine. And we can be the Hanuman's shoulder for all of our other department colleagues to ride on to expose the cause of primary healthcare, because primary healthcare should not just mean it taking care of coughs and colds and other things. While we should do that, but wherever and whenever possible, we should enhance the scope and see that our other colleagues like surgeons and oncosurgeons, and I have an oncosurgeon colleague who he's a part of our team and who is with us coming into the villages and talking to the gram panchayat, the village school children, the self-help groups. He's an operating oncosurgeon. He is a part of our tobacco cessation team, and he comes along with us to the villages. We have gynae oncology team with whom my colleagues work heavily, and we conduct camps whenever there is an opportunity. NGOs approaching us, government approaching us, we do these camps in collaboration with our gynae oncology colleagues. We have our obstetrics and gynecology colleagues with whom we collaborate and do our well women's clinic. So it's all of our colleagues at St. John's are there with us. That I think is a strength. And a couple of years back, while I mentioned to you all, I direct a community mental health program. One of the things that we do in this mental health program is not just taking care of depression and anxieties and psychosis and bipolar disorders, but we also have lots of patients coming with seizure disorders. While we are a psychiatric clinic, people also come, Naragala doc, in our local word, nerves doctor, and they also come to our clinic. So we have, while my psychiatric colleagues are sensitized in this, they handle some cases. We too have had a training program through our neurology department. We do some amount of that work. But whenever we are challenged, we reach out to our neurology department on the phone, and we have some patients to whom we could give the best possible care at a primary care center, at our level, at a primary care level, preempting the need for they coming to a large tertiary care center. So we also collaborate with our Department of Neurology. They have done 3 very large camps at our rural hospital, and all of those patients we follow up. So what I'm trying to say, Dr. Saab, here is, as MBBS doctors and as MD community medicine doctors, we have some orientation. While we can absorb all of that and do what we can, while we are doing that, there's scope for us also to enable our other colleagues to come and enhance the quality of the care that we deliver at primary healthcare. That's what I want to convey. So we need not work in silo. So we need not be on our own doing things. If we cross-collaborate, if we can impress upon our colleagues from the clinical services, then there is a great amount of quality work that we can do at a primary care level. It calls for some effort. It also, apart from attitude, Zara Dilka bhi, there is a role. They should also have a heart, but they are all doctors. And if we strike the right chords, I'm sure they will agree. Like in St. John's, I'm sure all of our medical fraternity across the board are the same. We all have the same genes. So it requires that striking the right chord, and we can get all of our colleagues, and we can get to see our medical students, our postgraduates. Today, I have with us postgraduates who come from anatomy, biochemistry, physical medicine and rehabilitation. Just yesterday, I was at our rural health center managing the Manasi clinic, and with me was my PMR postgraduate, on whom I bank upon for some of my cases, because in mental health, like you all know, somatization is one big thing. While we give drugs for the same, the SSRIs and other things, but it also needs a little bit of a physical touch. So while we do teach them some exercises, the physical medicine and rehabilitation postgraduate is with us. We involve them in interacting with this patient and talking to them. They teach some focus because they are the domain experts. They too get an exposure to these patients, and they do. So their mind and hearts, the horizon expands. It's not that no longer will they wait for a patient to be referred to the PMR department by other departments to do this. They also know, hey, here are the other departments where we can cross-collaborate and do the best we can do to our community. And when this happens, it also destigmatizes the whole thing. That's another advantage we have. All I'm trying to say is, when we cross-collaborate and when we expand the scope, there's great things that we can do. While humanity will be helped, it also enhances the scope of community medicine per se, is what I wanted to convey.
Yeah.
And apart from the clinic-based services, Dr. Saab, we also have a very strong medical social work unit. My colleagues are hand in hand with us, and everything that we do, They are with us, and everything that we want, they enable us doing it. And they are our windows, so to speak, for us to reach out into the communities. So that also is another important aspect in our life. It's not just us, it's our medical social work colleagues whom we have to take into confidence, and they too can strengthen our hands and enhance the scope of primary care and address not just the medical determinants, but also the social determinants of health. In fact, our medical social work department is very strong in organizing community-based organizations, and all the work that we do in our rural areas is through our self-help groups.
I think you have set up a really good background for our next phase of conversation. So
I'll just take 2 minutes. So all I'm saying is, so we are while we are there, we also have medical social workers with us in the department who enable us doing things, and we have clinical services which are based at the clinic. But most importantly, what is important is, while whatever we do at the clinic, it is also important that we follow up on them in the field. So in our department, we also have a strong workforce of community health workers who are linked to all of the clinics that I mentioned. We have community health workers who are with a disability. We have some community health workers with our senior citizen service. We have community health workers who in my own mental health program. So all of these health workers collaborate with each other, and whatever the work that we do at the clinic, they go and follow up on these patients whom we see at the clinic in their homes, in their villages. So there is a continuum of care. At primary healthcare level, that continuum of care is very unique. In fact, almost all of our colleagues who come from our hospital to work with us in all of these clinics that I mentioned, one thing that they tell us is, so what we like the best in community health department is, when I see a patient, I am guaranteed that the patient is followed up at the village, and what are the medicines or exercises I have told them, it is ensured that they are done by your community health workers. And our community health workers are not imported from Bangalore. These health workers are all women, and they are the daughters-in-law of the villages where we work. So they continue the care that we deliver to these patients or provide to these patients at the clinics, and they continue this at their households and their villages. While they ask them questions pertaining to medicine and illnesses, they also use these opportunities of going into the villages to help engage the community, which I'm sure Laharia Saab exposes the cause of. So there's another strong component in our department. They help engage. While community health workers do that, most often these community health workers are also accompanied by our interns and our postgraduates. So they collaborate and do these health educations in the community, so that community is empowered and community is enabled to take the decisions for their own health and not impose any medicines or any medical thought into them. It is to empower them. So that also we do, Dr. Saab. I think I will stop here, Dr. Saab, because we can keep on going. Before I hand over the session back to Subodh sir, all I wanted to convey to our friends who are watching this or hearing us out is, community medicine needs to be practiced. Yes, we have to teach. We are in a medical college. Teaching is our primary responsibility. We have to teach. And with specific respect to our subject, we have to practice it. There are challenges, I agree. But if we put our mind and heart to it, we can overcome those challenges. And we have to ensure that community medicine is practiced. Only when community medicine is practiced on the field, out there, our students will take the subject very seriously, and that makes a huge difference to the growth of the subject and the possible innovations. Thank you. Subodh sir, it's all over to you, and I'm open to any questions that come up.
Before I invite Dr. Subodh, let me put a few perspectives from your presentation that I think you made a few very powerful points. One biggest powerful point is that it is very much possible to deliver primary healthcare services through medical college network. You can teach, you can conduct research, and you can still deliver primary healthcare services, and that's a proof. But from my experience, I would say that very few medical colleges, on paper, all medical colleges, but in reality, very few medical colleges have that kind of community presence. And one of the challenge, and let me be a little rhetorical, in my opinion, it is a disservice to the postgraduate student of community medicine. We do not provide them that kind of opportunity. because many of them come thinking that this is what they would be exposed to. They are motivated at the beginning of training program, and rather at the end of 3-year training program, they should be more motivated. Many of them get demotivated because we de-skill them rather than upskilling them. And this is not rhetorical, this is a reality. So in my opinion, I personally think that it is responsibility of community medicine department in every medical college to plan that kind of services. We will discuss more about this. You highlighted second important point, that unlike other departments which have to work in a very structured manner, do certain things, it provides an opportunity for community medicine department provide opportunity for innovation. You can go to the community, you can like mental health services, other aspects you discuss about. So that's a very powerful motivation, both from academicians perspective, research perspective, because you have 3 facility as a department. And if you innovate there, you can guide and lead other. Third point you made is a collaboration or interest of other departments. And of course, it will come only when you do something substantial. And if you do something substantial, other departments would be interested. Now I want to start with Dr. Subodh with a little rhetorical question. In my opinion, in India's medical colleges, the community medicine department have lost the community component. Preventive and social medicine department do a bit of preventive, but social component is lost and medicine is barely there because the clinical skill do not practice. So how, Dr. Subodh, you work at institutions, so many at a leading institute which does community outreach services, how we can bring community in community medicine and social medicine in preventive and social medicine departments? And you can reflect other points. Over to you, Dr. Subodh.
Yeah, thank you so much, Dr. Chandrakant. I would like to appreciate you being so bold and putting this upfront that community medicine department, a majority of them may not have community presence. So, of course, there are departments which are working there, but more and more departments need to have community presence. I would like to tell that it's possible. Already, Dr. Ramakrishna has pointed out how at St. John's they are doing. And we at Sevagram, Mahatma Gandhi Institute of Medical Sciences, Sevagram, have similar experience. I would tell you one thing that right now when we are talking about this, there is a camp going on. So at Sevagram, we have a village adoption program, and this was just started in 1969 when the institute was just started. So this is our 54th village that we have adopted under this program. So without any break, we had been doing this, and we have excellent response, both from the community and also from the students. So sometimes we might be apprehensive that community would not respond or students would not respond. It's not true. They respond very well. Community is ready. Students are also ready. I would also say that even health system is ready. They are also looking forward to us, that we partner with them, we innovate, and we show them a path. So, but we'll have to learn. We'll have to learn skills on how to engage community. So if we don't understand that dynamics, it may not be possible. I would like to tell that at Sevagram, what we are doing. So in short, maybe 3 or 4 minutes, I would tell what we are doing. And I would emphasize mostly on the community engagement part. So we are also working at hospital level and delivery of clinical services, but one strong component at Sevagram is related to community mobilization efforts and how we engage with them. We have a field practice area of approximately 90 villages, which are spread over 5 primary health care centers. And we have very strong presence in these villages. So we have self-help groups of women. We have adolescent girls group, and we call them Kishori Panchayat. In some of the villages, we have farmers club. We strongly engage with village health, nutrition, sanitation committee, and gram panchayats. But community is on one side. We also partner with the health care delivery system, so district health administration, and not only health sector, but also ICDS. So we have very close relationship with ICDS and all Anganwadi workers. Earlier, 2003 to 2009, we implemented USAID supported program where we went ahead with a concept of community health volunteer. At that time, we called them Clicks Doot, and many or most of the ASHA worker today who are in these villages, our field practice area, are actually trained by us. So we get very good support from them, and that helps. But one thing that we practice is we do not duplicate the services when it comes to working with the healthcare delivery system. We do not duplicate their services. Rather, we try to do value addition to those services through our rural and urban health training centers. And one approach is we need to find out what are those components missing. So I would like to say that over the last 10 years, we have worked extensively on early childhood development. And today we are at a position where government of Maharashtra has accepted the model, especially Department of Women and Child Development has accepted the model of early childhood development developed at MJIMS Sevagram. And UNICEF supports a state resource team at Sevagram of approximately 15 members who these members are doing training of ICDS supervisors all across Maharashtra. Similarly, so basically we have entered in an area of implementation science or research, and we are able to support not only the district administration, but even at state level, the system in how an innovative idea can be implemented. So as I said, this is possible to do it. Dr. Ramakrishna has already pointed out some important messages, and you highlighted them. So especially the partnership, I would say we need to partner with the community, with the health system, and also with other sectors, other NGOs. So all possible stakeholders, we should partner, and we should demonstrate how primary health care, even work on social determinants of health could be catalyzed. And we need to learn, and we need to create an environment, a platform where our students learn how to partner with the community, engage in community health action. And our experience tells that this is possible. Again, I would say that there are lots of challenges even in our setting. Dr. Ramakrishna pointed out, even at Sevagram, there are challenges, and we also need to move forward, maybe do more. But this is need of hour. And when it comes to, say, providing healthcare to the people, it is very important that I believe in early childhood development, and I also feel that when our MBBS doctors join, this is their early professional period, and that early professional period, akin to early childhood, whatever they see, whatever the role models they have, that will have immense impact on them that cannot be reversed later. So we need to have excellent role models available to them. Like we say that parents have to do role modeling. Here, when it comes to medical colleges, the teachers, and especially for primary healthcare, the teachers in community medicine or community health, whatever name the department may have, they need to play or do that role modeling.
Thank you very much, Dr. Subodh. So I'm sure after listening to both of you, Dr. God and Dr. Gupta, many of the community medicine postgraduate students and then early career professional would be very excited that the potential which exists in the department and the training which is imparted. Unfortunately, I have to say this, that not every student get that kind of opportunity because many departments are not providing those primary healthcare services. So that brings me to the question that if 10 medical colleges, 50 medical colleges across India can do, then of course each medical college can do, and with the limited resources not additional, but the question many times medical colleges, community medicine departments say that they don't have resources, they are overstretched. But that should not, or that does not mean that it cannot be started. Of course, additional resources would be needed as we scale up, but there are existing facilities, or with some motivation. Both of you, like I'm seeing the chat in the group saying that the level of energy and motivation and the interest which you do, that takes us very long. And then to sustain it, you require additional step. So my question is that if a medical college, a Department of Community Medicine want to revive those community outreach programs, what are the 3 bullet points or 3 things they should do? Not necessarily 3, it could be 2. Or what would you advise if they ask you, both of you, that okay, we want to scale up, what should we do? What would be your advice? And I request, because we would like to wrap up this in next 10 minutes, so please be very succinct, and we will find another opportunity to elaborate. We will explore what can be done to continue this dialogue. So what advice you will give to a medical college head of the Department of Community Medicine to start or expand outreach services? Question first to Dr. God and then to Dr. Gupta.
Dr. Sab, we can speak many things, but all of our other fraternity will be very angry with us. But anyways, but one thing, I think, like I said, all of us are the birds of the same feathers, and we all have the same gene. And the gene expresses itself depending upon the environment, that is created for it. That's the ultimate thing. After having said that, Dr. Saab, we as community medicine professionals and our heads of the department, senior colleagues, faculty, etc., we have a responsibility. We have to be the torch bearers or the flag bearers of our specialty. वो तो होना ही है. Having said this, there is also the responsibility of the institutions, the deans, the vice deans, the heads of the departments of our other departments in the hospital, including the chief of medical services. They do have a responsibility. They have to create an enabling environment for our department, that is departments of community medicines, to see that we deliver quality primary care services. Like I said, probably why our colleagues at St. John's probably, or at Sevagram or CMC Vellore or many other medical colleges, forgive me if I have not taken all the medical colleges, why things work is because that there is an environment that is created for our departments of community medicine in these institutions to do the work that they are doing. It should be the same case in all the medical colleges. All the medical colleges, heads of the institutions should see community medicine as one resource, and they should enable the department to deliver things. And at this point of time, let me be very frank, not all of our colleagues may have that kind of an environment, but we have to fight for it. We have to advocate for it. And once that happens, we will be able to take our subject to greater glory, Dr. Saab.
Thank you.
To summarize, the heads of the institutions have a responsibility to create an enabling environment for our departments to do the work that they are capable of.
I have a difference of opinion. Head of the institution will not be nudged unless head of the departments will nudge them.
I said that. First it begins with us. We have to hold our own flag. But the environment needs to be created for us.
And also, and this is a conversation. So I also want to chip in. I'm relatively young, but then I would say that when you want to break like this, there is a status quo for long, and if you want to break that status quo, it will take a repeated effort. So it will not happen that the head of the department should get discouraged. And especially now in the medical colleges, with the expansion of number of seats, there is an expansion of faculty. I think the early career or mid-career faculty member need to be torchbearer, because the fruit will be born like a 3-year, 5-year, 10-year later. So we need to make a repeated effort. And that's what is required. Then only the head of the institution head. But another question, and then Dr. Subodh probably will join. If that is the point, then what happens in many of the places, many of the medical colleges, head of the institutions are from the community medicine. Why can't they do that? Over to you, Dr. Subodh, with this rhetoric.
Okay, fine. So I agree with what Dr. God has said, and a few things I would like to add here. Already it has been discussed, but I'm again putting it. It is about feeling excited. It is about understanding the importance of the discipline we are practicing. Need to value that and come out of our comfort zones wherever we are. I fully agree with Dr. God that it is the environment. At Sevagram, we are also fortunate to have an environment, an institute which was started none other than Dr. Sushila Nair, and has been nurtured after that by so many great people who have names in public health. And they have created that environment where we are able to thrive. So we must understand that. And that environment has to be created, but it needs to start somewhere. And of course, the current faculty, senior and junior, they will have to come forward, understand the importance, and begin. In this process, when it comes to community medicine or community health, it is different from clinical medicine. We'll have to come out of that mindset. It requires lots of partnerships. We should be ready for those partnerships. So basically, unlearning something and learning some new things, and that may not have happened everywhere for every professional in community medicine. This might be the situation. So we'll have to take lead on that. I would again emphasize on the same things that Dr. God said. It's about institution and about a larger environment. That larger environment is important, and the support is required. One thought that I always get, and I'm going to articulate it here, is about some minimum standard requirement that we have through NMC. And unfortunately, this minimum is read as maximum by many administrators, and I have lots of problems with that. So when we start doing something, it is important for the institution to understand that these are minimum requirements, and according to need, additional manpower facilities should be there. And unfortunately, maybe the requirement, especially I would say also for faculty, but when it comes to support staff, the PHM, A&M, social workers, probably these requirements should be more. Like now NMC has advocated family adoption program, and the family adoption program may not be possible with the existing resources the departments have. And the faculty in Department of Community Medicine at many places might face lots of hurdles in that process. So that is another important thing that I'm pointing out. And then it is about creating platforms where we are able to exchange ideas and learn from each other. And we need to require to create this kind of environment. And like organizations like you are taking lead, or IAPSM or IPHA and many other organizations may take lead on this part. But one thing that I would like to emphasize, that when we come out of our comfort zone and we are ready to make change, it is going to happen. It's the statement that we have learned, the quote that universe conspires, that actually happens. So if you are passionate about making a change, the whole universe will conspire. So how much passionate you are from within, it is also about that.
Thank you very much. This is a discussion which can go on for long.
Yeah, I know.
One of the point I heard is that this need to be a dialogue process. This need to be discussed at different level, and the professional association take it to the right forum, the head of the department take it to the head of the institution. But then my question is, are professional association taking it to the next level? Is there enough discourse around to bring the change? Because unless you discuss a different platform, unless we start thinking together that how to make it better, the status could remain. And I have no hesitation in saying this thing that many professional conferences happen, like a number of sessions happens, but the kind of things that how to improve the quality of education, how to improve medical colleges, those kind of panel discussion, those kind of discussion do not happen even on the side track, forget about the mainstream platform. So do you think the professional platform need to be more active? And let's not take the names without clear this thing that is this a time that there should be a sustained regular dialogue at the national level to ensure that how additional medical colleges strengthen their primary care outreach? Is there a need for some other platform where some of the institutions which are already delivering good community health services engage, collaborate, and some I don't know the mechanism, it could be through state government, national government, that institutes, Department of Community Medicine collaborate with each other to strengthen the capacity, professional association support this process. What are your reflections? Dr. God, again in the same order, and then Dr. Gupta.
Chandrakantji, first of all, Subhoji made very pertinent point in the current context of NMC. We can't keep on flogging a tired horse, right? While community medicine can do many things, including the family adoption program. While family adoption program is an institutional program, but you know what happens? It comes and sits in our lap. Okay, and I think looking at it positively, it's again one more opportunity because that will give us more time to be with the students, and that time, if utilized well, we can expose the cause and the spirit of community medicine and the primary care, and impress upon the student what this subject can do if you apply yourself. While that is an opportunity, but like Subhoji rightly pointed out, we need extra human resource as well. With the same number of faculty, with the same number of designated resources, we cannot we should not be expected to do everything. We need, that's where I said, there is an ecosystem that needs to be built around our department. And for that to happen, of course, like you very rightly pointed out, I agree with you, Chandrakantji, the department should voice it out and ask for it, and with reason and with a pitch, so that it is given to you. So, but I just wanted to concur with Subhoji that yes, departments need to be supported with the human resource. One. Number two, to ask your question, to answer your question, Chandrakantji, community health is everything about coming together. So all of us in the community medicine departments should keep our hats aside. We must start coming together. And in a very small way, at St. John's, we have invited our colleagues from the neighborhood colleges to come and see the work that we do. In fact, I said, you please come here, St. John's College, you come there, and there's an annex. We will take care of your accommodation and all. Come and see what we are doing. And if there is any scope for us to come there, we will also come. So those kinds of things have happened, but that have happened at a very friendly level. Just say, you have asked for me to be with you, and Subhoji also has come. So, but it should be at a professional level. Guys, here are you guys doing this. We know that this is your expertise. Your department is going in this direction. Can we come and be a part of this? Can we come and have a look at what you are doing? Likewise, we also invite you to our department, see what we are doing. So if that openness comes, if we all can come together, we will be exposing the cause of our subject well, Dr. Sab. We should come together. We should not have hesitation. And community health departments don't compete with each other. It's everything. Our competition is how best we all come together. Unlike many other departments, we have done this many number of procedures, this many number of implantations, this many number of this thing. Our subject is about, how often, how frequently have you collaborated? What is your sustained effort? What is your length of collaboration in a sustained way? These are our measures of strength. So I think we all should, our department should come together without hesitation, and we all should be open to share our knowledge and expertise with our colleagues, whoever is wanting to do. In fact, as we speak, there is a request from a government medical college to my department. The HOD there, a senior gentleman, said, no, I want to bring all of my faculty to your department. And we had no hesitation in welcoming them. Okay, please come. And we have, in fact, deferred all of our other programs in the department. Our head of the department has spoken to all of us and said, guys, we have to be open and let them come. And one good 3-hour session with our colleagues from the government medical college. Let them come and ask and see what we are doing. And we'll be sharing, including Dr. Saab, you will know, sharing of the timetables and the notes also, whatever that we have at a professional level. So to that kind of openness, we have to go, Dr. Saab. This augurs well for our department, and that kind of an openness is the one which is required. We must come together and collaborate and be open to sharing of our ideas and experiences. Thank you, Dr. Saab.
Yeah, Dr. Chandrakant, I would just like to add that you talked about associations. I would say that associations are made of people like us, all the members. And if these we members start voicing in more number our concerns, this is going to happen. I also see that, as Dr. Ramakrishna also mentioned, I see that there are lots of interest. So almost similar phenomenon as he described happens at Sevagram, and in the last 1 year, probably 3-4 medical colleges, they would have visited our institute, and they would have tried to understand what we are doing. So this is happening, especially the younger faculty, and we have a few workshops that we conduct, and they show lots of interest in what the department is doing. And if we as a discipline all across the country do good work, this will also invite good students to take community medicine or public health as their career. And that happens. They, as I said, it's not, we should never blame the students. They are looking towards the discipline. They are continuously trying to understand, it's not about themselves. It is also about in what position, through which route they would be beneficial to the community, to the nation, to the healthcare. So they are looking forward. And if we are able to rise, we are able to provide or give them confidence that what is the function of the department, and when you are trained in this discipline, you will be able to deliver. You will get those requisite skills, which makes it possible that you are able to deliver, bring in change. They would come forward. I strongly believe in that. So we all will have to come together, and associations also should discuss more about it, the real thing. And I agree to that.
Thank you very much. I think this is a really interesting and exciting conversation which can go on for long. For the time being, for today's conversation, we would close shortly, because I do not want to prolong beyond 1 hour. But the key point is that this is a conversation to be continued in different form. We will definitely revisit, we will meet different set of people and continue this. But before I close, I want to thank many of the participants who have written their comments: Emmanuel Joshua, Tamija Naban, Dr. Venkata Rao. Smriti is asking question. I think I should take one question. This is for Dr. God. The question is, are these services which you talked about are free? What about laboratory and other diagnostic services? And what about collaboration with other national health programs? So that's a question for you about the cost of services.
You are muted.
You are muted, Dr. God.
So the laboratory services at this point of time, we have a collaboration with, we have identified one lab which is closer to our rural health training center. Earlier, we used to draw the samples and we used to take to our hospital, and our biochemistry colleagues and the pathology, they used to help us out. But then we said decentralize everything, and to our rural health center, very closer to our rural health center, a distance of 5 kilometers, there was a laboratory set up. And the lady like us, who has worked, the chief of that lab, who has worked in many underserved areas in deserts and everywhere, she approached us. So why don't I collaborate with you? And she actually is deputing her staff to our rural health training center. She comes every day for about 4 hours early in the morning, collect water the blood samples, and they send. Now with the technology in place, most of our patients also have, the smartphones, so they get reports on the smartphones. They also supply as a physical form, with the patients come and collect. So that's what we are doing. And she, for the sake of our patients, has subsidized the cost for our patients. So wo chal raha hai, doctor. So then, as regards to other services, most of our services are free for the people who, like I said, we have a very strong community health workforce and medical social work. We go by their guidance. And like our director in the past said, nobody shall be turned away from the doorsteps of St. John's for the want of money. We go by that philosophy. So those people who can give us some amount will take. Those who cannot, we provide our services at no cost also, Dr. Sir. Cost is not a big concern for us at a primary care level. But if I'm again asked about sustenance, then we are in. So like you have heard me saying at the Wipro conference where we met, sustainability comes at a cost, and we can sustain the services only when we charge our patients. And our patients, what do we charge our patients, Dr. Saab? Especially in rural areas and all, there is still poverty is all pervading, and we really cannot charge the patients. So we will 100% need, again, the support of the institution and the charitable institution, the NGOs, to support our primary care services. And at this point of time, by Almighty's grace, we have that support, and we are able to do and pass on those benefits to the community.
Thank you very much, Dr. God and Dr. Gupta. Wonderful conversation, very engaging. And I could have continued for long, and I really wish I should have continued. But in the interest of time, we will close. What we might not have given answer to every question to our viewers and audience, but we definitely shaken the sleeping elephant. Like now, when when elephant gets up, like it takes a right turn, a left turn, and then front part and back part, and then before it gets up, stand up, it is like a long process. And that seems to be like, that's a very, in my opinion, that's an analogy of a community medicine department, that they are working at certain pace, but before they will have an accelerated pace or additional work, it will be a process. But we have started a dialogue in this direction. Hopefully, people will reflect about this. We will revisit these aspects, will bring additional people, will continue to have this dialogue to ensure that we bring back the community in community medicine and social medicine, preventive and social medicine. And in the end, the beneficiary would be the people, public, community to whom we want to serve. So with this, I say thank you very much and thanks. Take care.
Thank you, Dr. Sir. Thank you very much. Thank you, Subodh sir. Thank you. Thank you.